we are in our CAST lab in Pediatric Cardiology Division, Cairo University. Here, me, Hala Agha, Dr. Sahar Shakir, and Dr. Ahmed Abdelwahed and Dr. Osama Abdelaziz, and our great team, Dr. Dua from anesthesia team, and Ahmed and Muhammad, and Muhammad, our technician. We'll start our procedure in a tiny baby, 1 week, 2.5 kilo, with the critical pulmonary stenosis, and he's presenting with severe cyanosis, and we are planning to do balloon dilatation.
Our case, 7 days old female patient presented by neonatal cyanosis with oxygen saturation 84%. Patient with not distressed and tolerating oral feeding. Regarding the physical examination of the patient weight is 2.5 kilogram. Normal vital signs, the patient is not distressed, heart rate is normal for age. Oxygen saturation 84. Regarding the cardiac examination, there is quiet pericardium and no signs suggestive for cardiomegaly. By auscultation, there is normal S1 with diminished S2, and there is ejection systolic murmur with maximum intensity on the pulmonary area. Chest examination and abdominal examination is normal. Here is the ECG of the patient. The patient is sinus with normal axis. There is no right atrial dilatation. There's normal PR interval and normal QRS. And there is right ventricular dilatation. Regarding the chest X-ray of the patient, there is right ventricular configuration in the cardiac shadow with apex tilted up, suggestive for right atrial dilatation, and there is lung oligemia, normal CT ratio. Regarding transthoracic echo, from the subcostal view, there is stretched BFO, stretched beta foramen ovale, with pure right to left shunt. From apical four-chamber view, there is right atrial hypertrophy with average size tripartite right atrium and good tricuspid valve annulus. There is tricuspid regurg. From apical four-chamber view with some angulation anteriorly, revealing aliasing in the RVUT and the pulmonary valve. Is modified short axis, revealing the pulmonary valve with thickening and systolic dooming of the valve and the fusion of the cusp. Here's another clip, reveal the same finding. With color mapping of the RVUT, there is pulmonary regurg, and there is poststenotic dilatation, Doppler flow across the pulmonary valve, revealing pressure gradient around 77 millimeter mercury. There is measurement of the annulus from hinge to hinge during mid-systole, as we see, 0.7 centimeter. And another color mapping across the pulmonary valve and the pulmonary tree. There is poststenotic dilatation and the good-sized pulmonary arteries.
It's a pleasure. We're going into a critical PS infant, as Dr. Hala Agha just mentioned, and we're going to start by using Seldiner technique, introducing a 4 French sheath, which we plan to put on the right femoral vein, and from there we're going to proceed and do with our Judkin right 4 French to try to reach the pulmonary valve to do a balloon valvuloplasty. We're going to see after the injection, confirming the annulus measurement,
and see if we're going to do a grading for the dilatation or just on one step with the we decided as a team to use the mini Taishik balloons. So we are going to see which, after the injection, how we're going to proceed.
Adjustment of our, yeah.
Okay. After flushing the 4 French Zetkin right catheter, we're proceeding putting it on a trauma wire and trying to go from the femoral vein to the right atrium.
Your wire, please.
كده مسموعة أحسن.
Okay. Please remove your wire and we'll measure.
And diastolic pressure.
You are ready?
Yes.
Okay. Okay, perfect. Please assess our annulus. Okay. Yes. No, the previous one.
Lateral projection of RV angiography revealing a thickened pulmonary valve with evidence of systolic doming and a post-stenotic dilatation. Pulmonary valve annulus measuring around 6.8, around 7 millimeter, with looks of a dynamic infundibular element 2. So we are deciding to choose our balloon for dilatation further on. We removed the contrast from the patient, and now we're going to do a clockwise rotation just to be in the RVOT and try with the trauma wire to pass through the stenotic pulmonary valve.
Our wire?
Okay. I think we need to be posterior.
Okay. Gently across the orifice to avoid any traumatic injury of the right ventricular outflow.
مش عاوز really posterior. We're very interior.
Okay. No, stop, please.
Yes, we're very interior. That's better. Even more posterior. Okay. Okay.
Try by this way.
عديت
واير كده يا سهى.
نفتح
بلشويش. Where you are?
I think we passed. Yes.
I'm not sure.
طب ثانية بس.
withdraw الواير حاجة بسيطة.
لا definitely we passed you ترى. اهو استني بس عليا بس كده. not bad.
ماشي.
not bad at
okay. We are inside the PDA, not detected by forceability.
Yes.
And then we go to the ascending aorta and to exchange our okay.
Proceed with the catheter.
Tension, withdraw some. Okay.
Maybe the orifice is very small.
Yeah.
Yes, we passed. Okay.
Okay. على ايدك يا دعاء. ايدك يا دعاء. يلا. Okay. I am in. يلا واير. خدي على ايدك oxygen.
Okay.
يلا. I withdraw.
I will take the catheter away and keep the wire in.
Okay.
You're holding the sheath. Okay.
عاوزة بروسين. I want بروسين now. I want بروسين.
ادي واحدة نضيفة يلا محمود. Now we're going to introduce over the coronary wire our mini Taishik balloon, and the plan is to inflate at from 3 to 3.5 atm pressure. لا خلينا
withdraw the wire.
Just open frontal so we can
adjust the wire.
Adjust it. Yeah. Go ahead.
tension the wire, please, to avoid any loop
يلا.
inside the right ventricle, which impedes the flow and the progress of the balloon. I think we need more tension. We need more tension.
Yes, I think it's
Yeah.
it's lodged.
I think it's wise decision to try by balloon, by coronary.
First and then do it as staged. Okay.
Yeah.
Okay.
Withdraw, please,
Okay.
Sahar.
I will take the balloon off. Away.
Coronary balloon. Okay. We remove. Okay. Perfect. Your tension of over the wire. Okay. This is the okay. We'll go down and
Yes.
inflate, please.
يلا يا
Mahmoud, please
محمود.
inflate without
من
air.
12 from this is from 12 at births at 22 ATM, so we're gonna start with perfect 1 2 3 4 5
Okay,
6 7 8
perfect.
9 10 يلا.
Yes.
Deflate.
Okay.
Yes.
First by the 10 after trial of
يلا.
advancing for this severe pulmonary stenosis. مبلول مبلول يعني جي مبلول.
جي واحدة كمان. اديني الواير. فين؟
withdraw الواير يا سحر. more. Okay.
يلا يا محمود. بسم الله الرحمن الرحيم.
more tension.
بس أدخل الأول.
لا.
وبعدين حامل تنشن.
Okay. more tension. Okay. more.
سنة
more.
كمان. سنة كمان.
Okay. need few
Yes.
few millimeter. Okay.
Let's adjust. يلا. أيوة. كمان.
بس.
I think this
I
is
think.
good.
Okay.
We're proceeding with the multi-purpose
Now
for
on the
French to
descending
do
aorta.
in the descending aorta.
Rami?
I'm doing a pullback from the aorta, PDA, MPA, and then the RV. محمود خد.
Okay. And the patient is
hypotensive
hypotensive.
قوي. دعاء.
Okay.
ادي fluids حبيبتي.
This is a PDA. MPA. This is the right ventricle. Now the gradient by pullback is around 40, but now is 20 by the presence of PDA. Thank you.